We'll be looking into the topic of choosing the right antibiotics, right antiepileptics in office practice. எங்கள் ஊருக்காரங்களாம் வந்துட்டாங்க. So, I'm just sticking to the topic. We are choosing antiepileptics to the epileptic children. Okay? So, the aim and objective of the topics is to talk about different types of epilepsies and different anti-epileptic drugs and how best we can marry these two to attain seizure freedom. So the whole idea is to get the child seizure free. So everybody says aims and objectives. I have given here a negative objective. What I am not going to do, and it is as important as finding a negative history in a child or in any patient. I will not go into the details of how to diagnose epilepsy, it's a topic on its own, and I will not go into the molecular level of epilepsy or the receptors or the antiepileptics, how it is going to go into the pharmacological mechanism of action. We will not go into the details of investigation, MRI or EEG. Keto diet, vagal nerve stimulation, epilepsy surgery, we'll just touch upon because each one is a day full of course. Neonatal seizure and convulsive status, intensive care people can handle. So how do we classify epilepsies? It's easy. How do we classify human being? Male, female, and then there are some people in between, indeterminate. So you have generalized epilepsy, you have focal epilepsy, and you have by either a history or a video scene of a event, actual event. So it is very, very important to diagnose the type of epilepsy. You don't need to go into the intricacies of the epilepsy. All you need to find out is this generalized or is this focal? That's all you need to know. You don't need to know anything else. So if we classify these two, then each of them will have three. We put it into idiopathic, symptomatic, and cryptogenic. So what is idiopathic is idiotic on the doctor's part. We idiots, we don't know anything, and pathetic on the patient's part. That's what the idiopathic means. So you have a child who fits, and we don't know why the child is fitting. You have done all the investigation, whatever you could. But still the child is fitting. So it is epilepsy, it is idiopathic. Symptomatic, you investigate, you find a reason for the seizure, then it becomes symptomatic. Cryptogenic, you investigate, you find something normal, but the child is fitting, but on examination the child has got some soft neurological signs or hard neurological sign. Then it is encrypted. So it is called cryptogenic. So you have 6 types of epilepsy. You have idiopathic generalized epilepsy, idiopathic symptomatic epilepsy, idiopathic cryptogenic epilepsy. Same wise, idiopathic focal, idiopathic symptomatic, and idiopathic cryptogenic. And the few syndromes are there, we'll see along. This is based on International League Against Epilepsy classification of 2017. Types of anti-epileptic drugs, don't worry about going into the details, I won't bore you with it. You have like broad spectrum antibiotic and narrow spectrum antibiotic. You have narrow spectrum anti-epileptic drugs, broad spectrum anti-epileptic drugs. If you know the narrow spectrum, the rest of them are all broad spectrum. Narrow spectrum is carbamazepine and its related thing, and vigabatrin. Those are the two main things, and the last newer one is tigabayne and then gabapentin. Those are the only 3 group of drugs which are narrow spectrum. You can safely refrain from using it. You can use the broad spectrum for any epilepsies. Older ones, newer one, you all know, like phenobarbital, phenytoin, valparin, carbamazepine, they are all older ones. The rest of the things are all newer antibiotic drugs. So this is all I'm going to say about the classification. We'll go into the general principles, like the success lies predominantly, 95% of the success of a treatment lies on your classification of epilepsy. So get your history right and then the diagnosis right. And depending on the age, you can choose the anti-epileptic drug. And there are certain types of epilepsies where you don't need to treat. For example, Rolandic seizure, if it is self-limiting and it's happening in night, it will settle down. You don't need to treat it. With possible interactions to other drug, if it is teenagers or young women, they may are using contraceptions or they may have some other drugs for some other problem, comorbidities, then consider the drug interaction. Monotherapy is wherever possible, and most of the time if you get your diagnosis right, you will treat them with monotherapy. When you are going into second or third drug, you don't know what you are treating. Commencing and weaning, you slowly start the drug, reach a therapeutic level, and then slowly withdraw as soon as the seizure freedom is obtained after 2 years. Don't jump quickly. If you titrate the dose up quickly, you encounter side effects quickly, and then you may have to reduce it. So slowly do it. So generalized tonic-clonic seizure is a generalized, it can be anything, idiopathic or cryptogenic or symptomatic. First line is sodium alpurate for boys. For girls or more than 10 years, you can use lamotrigine or levetiracetam. So what I am saying is, first line you try with sodium alpurate. If it is not settling, use levetiracetam and then use the levetiracetam and then come down on the sodium alpurate. Still you are using one drug. If the second one is not working, then add on the clobazam, perampanel, topiramate or whatever you can add. Don't use the narrow spectrum one. Second line is the more newer ones. Focal seizure without secondary generalization. Use levetiracetam as your first line, not carbamazepine. Yes, it is focal, but if it is without secondary generalization, use levetiracetam. Third line is your lacosamide, and then the add-on, you can see carbamazepine, lacosamide, lamotrigine, levetiracetam, oxamide. The list goes on. Nobody needs to write anything. This is all available at the end of the talk. I'll give where you can find out. You can have a handout. Absence seizure, if you are pretty much sure it is absence, you need an electrophysiological diagnosis to confirm it is absence seizure, nothing else. Then use ethosuximide. Second line monotherapy is valproate. Third line monotherapy or add-on is your levetiracetam. Absence with other seizure type, this is more common one, this is more troublesome one, this is more difficult to diagnose, this is more difficult to put a pen and paper and say what type of seizure we are having. So this one use sodium alpurate for boys, for girls it is levetiracetam for teenagers or lamotrigine. Add-on you can use ethosuximide here as well. Myoclonic, first line is sodium alpurate, second line levetiracetam, other add-on you can name whatever you want apart from narrow spectrum. This I want you to remember, this may be your take-home message. Contraindications for absence, myoclonic and JME. Please do not use carbamazepine. If you use carbamazepine, you will aggravate the seizure. If you don't get the history right, you will use carbamazepine. They may sound focal. Tonic or atonic, again first line is sodium alpurate. Second line monotherapy add-on is clobazam and topiramate. This atonic seizure is notoriously difficult to control. Here comes your ketogenic diet, which in itself is very, very difficult to follow. Felbamate, we don't have it here. Dravet, this is something called severe myoclonic epilepsy of infancy. If you want, you can have a genetic diagnosis where it is SCN1 gene. Monotherapy is valproate. Triple therapy is, if you have a difficulty, use sodium alpurate, clobazam and stiripentol. Stiripentol is available now. You can get it for the hospital, you cannot get it for the patient. Ketogenic have been tried. Lennox-Gastaut, first line is again sodium alpurate, second line is lamotrigine monotherapy, and then add on clobazam, topiramate, felbamate or ketogenic diet. Infantile spasm syndrome, if it is not due to tuberous sclerosis, use high-dose steroid to start with, plus or minus vigabatrin. If it is due to tuberous sclerosis, you can use the triple therapy. Levetiracetam, nitrazepam and topiramate in combination works better. Ketogenic diet, again, these are all last resort or a dustbin use. Myoclonic dose, which is again another difficult epilepsy to control, where you can use sodium alpurate. Here, topiramate works better, but this has been given as a third one on the third line. Ketogenic diet is used for all the difficult epilepsies. We don't need to worry about it, and it is not for normal pediatricians to handle it. Resective epilepsy, like with the ketogenic diet is an add-on thing. If you put somebody on ketogenic diet, you can't come off the antiepileptic drug. Whereas epileptic surgery, if you choose your patient, if you do the surgery properly, it is curative. You can come off the medication and you are off the medication. You have become normal. You may have some sequelae here and there. You have to find a balance between, right, my left won't work after the surgery, but I don't have any seizures, or I will be fitting every day 10 times and live for my life. Which one you want to choose? You have to choose. It is a choose, it is very difficult to choose between hard and a rock. Vagal nerve stimulator, which is again an add-on one, and it has not become very popular, and it is more useful for movement disorder than epilepsies. I've nearly come to my end. Your take-home message: get your diagnosis right, then the treatment is easy. I put levetiracetam 3 times. I don't know how many of you have seen all the letters are black and white, only one letter was red. You have seen pretty much levetiracetam in all my slides except the syndromic ones. So use levetiracetam lavishly. You won't go wrong. It won't exacerbate any seizure. And if it is not getting under control, get a help from your neurology colleague or another pediatrician. Remember the contraindications for carbamazepine. Don't use it in myoclonic seizures. That's all I have to say. Thank you. And whatever I have said is based on this one. This is available as a 148 paper PDF, or you can have a A4 sheet. You can have it in your desk. Specifically, I have not gone into the details of the dosages because it's not worth remembering the dosages. We will forget and we will make mistakes. Better have a book with a reference dose and then stick to it. Thank you.
Thank you, sir.